Hi guys, welcome back to the channel. Today we discussing approaches trial hydrocortisone plus fluorocortisone for adult with a septic shock.
Disclaimer: the content and information on this video is for education purpose only and is not intended to be recommendation of any kind of son whatever. Under any circumstances, the author accepts no liable for any indirect, incidental, consequential, exemplary damages arising. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in an effort to advance understanding of educational content.
Clinical question: in critical ill patient with a septic shock, does the combination of hydrocortisone plus fluorocortisone therapy reduce the 90-day mortality? Background: use of steroid in critical ill patient continues to the controversial. With list there is a signal for the improved cardiovascular parameters. This did not translate the clear mortality benefit. The most recent trials of Adrenal 2018 concluded that among the patients with a septic shock undergoing mechanical ventilation or continuous infusion of the hydrocortisone did not result in lower the 90-day mortality and than placebo. Adrenal trial was discussed previously. You can find out the link in the description box. Design for the study: this is multi-center randomized placebo-controlled trial, double-blinded, initially designed to have 4 parallel groups to evaluate the benefits and risks of steroid and drotigrigor alpha DA in 2 by 2 factorial design. Original 4 groups 1, 2, 3, 4. Corticosteroid placebo plus drotigrigor alpha placebo. Corticosteroid plus drotigrigor alpha placebo. Corticosteroid placebo plus DAA and corticosteroid plus drotigrogin alpha. With the drotigrogin alpha was withdrawn from the market, the trial was continued within the 2 parallel groups, 1 and 3 combined and 2 and 4 combined. Randomized by permuted blocks of 8. Intention to treat analysis. Sample size calculation by based on anticipated 90-day mortality of a 45% among with a patient with septic shock. 320 patients required to each of the original 4 groups. 1,280 patients total for 95% power to detect absolute difference in 10% in a 90-day mortality. Setting for the trial: 34 French ICU during September 2008 to 2015 June. Trial suspended twice, October 2011, May 2012 due to the drotigrogin alpha withdrawal, and July 2014 to October 14 request of Data and Safety Monitoring Board to check the quality of the trial. Agent and the distribution of the serious adverse events. 1,671 patients screened, 1,241 randomized 4 groups. Population for this group study: inclusion intensive care patient with an indisputable or probable septic shock less than 24 hours. Septic shock defined as a clinically or microbiological documented infection, super score of 3 to 4, or at least 2 organ, at least 6 hours in duration. Vasopressor therapy for at least 6 hours to maintain systolic blood pressure of at least of 90-day mortality. Vasopressor therapy for at least 6 hours to maintain a systolic blood pressure at least 98 mmHg or mean blood pressure of 65 mmHg. Exclusion criteria: presence of septic shock for more than 24 hours, high risk of bleeding, pregnancy or lactation, underlying condition which would be limit the short term of survival, known hypersensitivity to the drotigrogin alpha, later the remove previous treatment with the corticosteroid. Baseline characteristics were similar: mean age 66 versus 66, male sex ratio 65 to 67, medical admission 82 versus 81, SOPA score 12 versus 11, site of infection unknown, lung uh, urinary tract infection, positive blood pressure 36 point versus 30.36, vasopressor administration, epinephrine or non-epinephrine, mechanical ventilation 92 to 91, RRT 27 to 28. Intervention hydrocortisone 15 mg IV bolus every 6 hours, fluorocorticoson 50 microgram tablet once in the morning, administered for the 7 days without the tapering. Placebo similarly apparent manufactured for the trial. Management common to the both groups. Before randomization, plasma total cortical levels measured before the 30 and 60 minutes after the IV bolus up to 50 microgram. Corticotropin. Other intervention were harmonized across the center according to the 2008 Survival Sepsis Campaign guidelines. National guidelines for the prevention of superinfection were not followed. Outcome, primary outcome, significant reduction in 90-day mortality in intervention compared to the control group. Intervention group 264 of 614 patients had died. Control group 308 of 2627 49 patients had died. Relatively rich 0.88. Oscillatory reduction 6.1. Number needed to treat 17. Fatality index 3. Secondary outcome intervention versus control group significantly in favor of interventional group. All cause mortality in ICU discharge 35 versus 41. All cause mortality at a hospital discharge 39 versus 45. All cause mortality at a 180 days 47 versus 52. Number of days that patients were alive and free from vasopressor up to 28 days 17 versus 50. Organ failure 3 days up to the 28 days 14 versus 12. Patient wean from vasopressor at the 20 days. Patient wean from mechanical ventilation 28 days. Patient with SOPA score below 6 at the 28 days. No significant difference between the groups. All cause mortality at the 28 days. 34 versus 39. Number of days that patients were alive and free from mechanical ventilation up to the 28 days. Mean versus 11 versus 10. Safety outcome incidence of serious adverse events 52 versus 58. Primary column. Primary outcome major 90-day cause mortality 43 versus 49. Secondary outcome all cause mortality 34 versus 39. All cause mortality in ICU discharge 35 versus 41. All cause mortality at hospital discharge 39 versus 45. All cause mortality at 180 days was 47 versus 53. Strength of the randomized control trial, multi-center trial, intention to treat analysis, appropriate primary outcome, appropriateness of antibiotic therapy recorded. Weaknesses: the trial was initially designed for power with the BA being a part of therapy. The withdrawal of BA has impact aspects of this trial, including the statistical power calculation. The statistical analysis published in supplementary material suggests to no interaction with the DA. Other treatment Sagability index for several of the outcomes, including the primary outcome in a favor of intervention, is in a single figure. Outcome of Sanchez test conducted in period and intervention was not mentioned or discussed in the main paper. Result discussed in supplementary material section, where there is no difference between the responder versus non-responder in those who from which Sanchez test was actually conducted. The trial was conducted using the Survival Sepsis Guidelines from 2008, which has been since been updated. Very sick patient population, high dose of vasopressor in the trial, population may limit external validity. Not all secondary endpoints, including the original trial protocol, reported in the findings of transcript. Author conclusion: in critical patient with a septic shock, in addition to hydrocortisone, and hydrochlorocortisone compared with the placebo was associated with a significant improvement in mortality at 90 days. Bottom line, the addition of fluorocortisone is impact plays well investigated compared to the hydrocortisone by itself. It is not only my current practice to administer these drugs for refractory septic shock. Primary secondary outcomes, including the safety profile, shows a trend in favor of the corticosteroid group. Consistent with the findings of the adrenal trial, I will continue my current practice using the hydrocortisone 6 hourly for refractory septic shock.